Total T3 is particularly helpful in diagnosing hyperthyroidism, including T3 toxicosis, where T4 may be normal. T3 measurements include both bound and unbound hormone, but since most T3 is bound, changes in binding proteins can affect results. Total T3 is not useful for diagnosing hypothyroidism because levels often remain normal until late stages, and severe non-thyroid illnesses can lower T3 independently of thyroid function. Free T4 and T3 are the most reliable ways to confirm thyroid dysfunction. Only a tiny fraction of T4 and about 0.3% of T3 is unbound and metabolically active, but these fractions determine physiologic effect. Free hormone testing is especially important when protein abnormalities are present, such as pregnancy, nephrotic syndrome, or liver disease, where total hormone levels become misleading. And this clinically is what we do: a TSH plus a free T4, and if a patient has a diagnosis, adding a free T3 to evaluate treatment improvement. A reverse T3 is another test you can add on, and clinically we see this done because it's an inactive metabolite produced when T4 is converted by 5-deiodinase instead of 5'-deiodinase. Reverse T3 is typically increased in hypothyroidism and non-thyroidal illnesses where peripheral conversion to active T3 is suppressed. So clinically, this value can be helpful in differentiating between euthyroid 6 syndrome from true hypothyroidism, although it kind of has a controversial role. I have measured this test before, but not commonly. And this is kind of showing when you would potentially see it done and when there could potentially be clinical indication. Basal body temperature has historically been used as an indirect marker of metabolic rate influenced by thyroid hormone. Normal basal body temp ranges from 97.6 to 98.2, measured on days 2 to 4 of a menstrual cycle in a menstruating AFAB individual. A low BBT may suggest hypothyroidism, while high BBD is less common and may indicate hyperthyroidism. You cannot use this as a diagnostic tool on its own, but it could support clinical assessment when correlated with symptoms. Now, last but not least, looking at our thyroid autoantibodies, TSI, or thyroid stimulating immunoglobulin, activates our TSH receptor, and it's characteristic of Graves' disease. Anti-TPO, or anti-thyroglobulin antibodies, anti-TG, are most commonly associated with Hashimoto's thyroiditis, although there can be sometimes overlap with Graves'. Antibody positivity is more frequent in AFAB individuals, elderly, and individuals with other autoimmune conditions, specifically type 1 diabetes or pernicious anemia. It's important to note that Graves' disease is the most common cause of hyperthyroidism, but it's not the only cause. It's driven by thyroid stimulating immunoglobulins, or TSI, which bind to and activate the TSA receptor. This results in unregulated hormone synthesis and gland hypertrophy. TSI is an IgG antibody, which means that it can cross the placenta, an important consideration in pregnancy. Clinically, Graves typically presents with elevated T3 and T4, suppressed TSH, and sometimes a smooth, symmetric goiter. Extrathyroidal findings, such as ophthalmopathy, are unique to Graves and help differentiate it from other causes of hypothyroid or hyperthyroidism. And this is showing the immunologic mechanism behind Graves' disease. A defect in T suppressor cells allows for an autoreactive T helper cell to interact with thyroid antigens, which it shouldn't. These helper cells then stimulate our B lymphocytes to produce TSI antibodies. Anti-TPO and anti-thyroglobulin antibodies can be present, though they are not the primary drivers of Graves' disease. And the key concept with Graves, it's a stimulatory autoimmune condition, unlike Hashimoto's, which is primarily a destructive condition. Because TSI mimics TSH, the thyroid increases hormone production regardless of the body's needs, which leads to the classic findings of high T4, high free T3, and low TSH. Often increased radioactive iodine uptake is seen as well due to a hyperactive gland. During pregnancy, TSI can cross the placental barrier and cause transient neonatal hyperthyroidism, so recognizing maternal Graves is clinically important. Ultrasound or uptake studies can also help distinguish Graves from thyroiditis, where uptake would be low. Radioactive iodine uptake, or RAIU, measures how much iodine the thyroid takes up at 6 and 12 hours after administration. Uptake varies based off of on iodine status and medications like amiodarone, contrast agents, or even topical iodine could suppress uptake. An elevation in RAIU is seen in conditions with increased hormone synthesis, like Graves' or toxic multinodular goiter. Low RAIU suggests hormone release rather than hormone overproduction. We could see this in thyroiditis, exogenous hormone ingestion, or even excess iodine exposure. This test is extremely helpful for differentiating the causes of hyperthyroidism. On the other end, our other autoimmune kind of edge of the spectrum to kind of close us out is Hashimoto's. This is the most common cause of acquired primary hypothyroidism. It is also an autoimmune condition, and it's far more common in our AFAB individuals, particularly between 30 and 50 years of age. Early in the disease course, patients can show signs of mild hyperthyroidism due to the release of stored hormone from the inflamed gland. Typical findings include high anti-TPO antibody titers and sometimes anti-thyroglobulin antibodies. Family history is common and the presentation can be relatively insidious. Recognizing an early euthyroid or hyperthyroid phase is key as patients eventually progress to overt hypothyroidism. In Hashimoto's, radioactive iodine uptake can be normal or elevated early on, but later declines as the thyroid becomes progressively destroyed. Over time, labs typically show low T4, low T3RU, and elevated TSH. These changes reflect a failing gland trying to respond to pituitary stimulation. Antibody titers in Hashimoto's tend to be higher than in Graves' disease, which can help clinicians distinguish between different autoimmune processes. And patients that have Hashimoto's may have firm or enlarged thyroids early on, or a shrunken fibrotic gland in advanced disease. So you can kind of see both ends of the spectrum. The thyroid may be tender due to active inflammation. Because gland destruction is gradual, symptoms of hypothyroidism, such as fatigue, weight gain, and cold intolerance, often will develop slower, and it's essential to correlate symptoms with antibody levels and TSH or T4 patterns to capture the full trajectory of disease progression. Moving on into kind of our last kind of clinical picture, euthyroid 6 syndrome describes abnormal thyroid labs in patients with severe illness, despite normal intrinsic thyroid function. Illness decreases conversion of T4 to T3, reduces RT3 clearance, and lowers thyroid hormone binding. The most common pattern is low T3 with normal T4 and normal TSH. In more severe illnesses, T4 and TSH can also fall. It's crucial to avoid diagnosing true hypothyroidism in these patients unless there is a clear clinical evidence pointing that way. You do want to treat the underlying illness, that's the priority. This shows kind of different patterns that can arise depending on the severity of the illness. Mild illnesses typically produce isolated low T3. Moderate lowers both T3 and T4. And in severe systemic disease like sepsis, MI, or advanced liver failure, TSH, T3, T4 may all be low. Unlike primary hypothyroidism, TSH is not elevated because the hypothalamic pituitary signaling is also suppressed. Recognizing these patterns prevents unnecessary thyroid hormone therapy, which does not improve outcomes. So, how do we take all these pieces together? Because screening recommendations differ among organizations. The American Thyroid Association recommends screening starting at age 35 and every 5 years thereafter. The AAFP focuses on high-risk groups such as women over 35 or AFAB individuals, or people with autoimmune conditions, abnormal physical exams, or family history. The USPSTF states that evidence is insufficient for population-wide screening. So ultimately, how do you decide? Well, use your best clinical judgment. That remains central. Screening is most appropriate when symptoms or risk factors suggest possible thyroid dysfunction. So these are some signs and symptoms, and they really are going to provide your best indication to request thyroid testing. So we can see kind of our highest suspicion symptoms, our intermediate suspicion symptoms, and low suspicion or non-specific symptoms where I'd need probably a bigger categorization of these or a patient in a classic clinical population to consider. On the prenatal side, prenatal care universal thyroid screening is currently not recommended. Instead, guidelines suggest screening high-risk women. I do screen all of my like infertility or fertility patients, as well as I would encourage a patient who is undergoing prenatal screening to consider getting their TSH tested to make sure that there isn't a hypothyroid state and to work on getting that thyroid in its optimal level or optimal range. Because pregnancy changes thyroid binding globulin levels and increases overall metabolic demand, untreated hypothyroidism can significantly affect maternal health and fetal development. So, some professional groups are still debating whether universal screening should be adopted. For now, it's not officially. It's more targeted screening at the first prenatal visit or by the ninth week is the recommended approach. Neonatal screening for congenital hypothyroidism is essential because babies often appear normal at birth due to maternal thyroid hormone crossing into the placenta. And without early detection, hypothyroidism, as we mentioned, can lead to permanent neurodevelopmental impairment. The ideal screening method is a simultaneous TSH and T4 measurement, which improves the detection of both primary and central causes. And testing occurs between 2 and 4 days after birth, allowing time for normal physiologic TSH elevations to settle. Prompt initiation of thyroid hormone therapy, ideally within the first 2 weeks, is crucial for optimal neurodevelopmental outcomes. And here's your test summary. Really, the ones that we're primarily using in clinical practice would be your TSH, free T4, and free T3 is really what we'd be looking at for our classic clinical pathway. And that's your run through our thyroid diseases and thyroid testing.